a call-in information. If you get disconnected, the toll-free number is 1-877-668-4493, and you can see the access code below. So if for some reason you get disconnected, you can reconnect to audio using this dial-in information today. We'll also be answering questions at the end of Dr. Hidalgo's presentation. So throughout the presentation, if you would like to ask a question or post one for her to answer following her presentation, please use the Q&A box. It's on the bottom right of your screen to type in your question, and we'll make sure we get to it at the end. Just to give you a little bit of background information, the Fiscal Health from Systems to Sustainability program helps ensure the fiscal sustainability of Ryan White funded grantees using 3 different methodologies. There are in-person regional trainings, one of which actually is going on today and yesterday in Anaheim, California. We also do individualized technical assistance, which is in-person and virtual, as well as online learning opportunities such as this webinar series that we are doing today. And this is a program that's sponsored by HRSA, HIV/AIDS Bureau, and administered by Health HIV. It's developed specifically for Ryan White grantees. That includes Part A and Part B subgrantees, Part C Early Intervention Services grantees and subgrantees, as well as Part D grantees and subgrantees. And here are just a couple of our fiscal health resources. There's a variety that are available on Health HIV's website. You can see the web address below. And to access it, you'll find the Fiscal Health program under our education and training programs on the Health HIV website. So there are several resources here among many others on our site. All of our webinars are archived on the Fiscal Health page of Health HIV's website. It's a long URL there, but again, if you go to healthhiv.org, education and training, you can find our Fiscal Health page very easily. And this webinar will be posted with the recording and slide deck in about a week, along with the presentation that happened last Wednesday related to complying with Ryan White fiscal monitoring standards, which will also be available tomorrow online, the slide deck and recording. If you have any additional questions, comments, concerns, or have issues accessing the archived webinars, you can contact Julio Fonseca, who's the program manager for Fiscal Health, and his email is julio@healthhiv.org. Following the webinar, you'll also be prompted to complete a brief evaluation on SurveyMonkey. We really appreciate your feedback. It's really essential to developing additional resources and learning opportunities. So if you would please take the few minutes to fill out those brief questions, we would really appreciate it. So without further ado, I'm going to turn it over to our presenter today, Dr. Julia Hidalgo. She's the CEO of Positive Outcomes and also a research professor at the George Washington University. And Dr. Hidalgo has worked in HIV/AIDS program financing, design, management, policy, evaluation, training, and TA for over 25 years. And she's a nationally recognized expert in HIV finance, as well as served as a technical advisor and consultant to HRSA. She's done a lot of work implementing Ryan White Program's payer of last resort policy, Medicaid and Medicare programs, healthcare reform, third-party reimbursement, and insurance and disability eligibility determination, which is the topic of today. So without further ado, I will turn it over to Dr. Hidalgo, who will lead today's presentation. Thank you.
Marissa, can you hear me now?
Yes, we can.
Okay, excellent. Well, thanks everybody for joining. I hear a little background noise, so for those of you who have not muted your lines, if you could, exactly that person, if you could please mute your line, that would be appreciated. If you need to take a call, please do not put us on hold. Although we enjoy your hold music, it will distract us a little. back on the front burner over the last couple of years with the implementation of the Affordable Care Act. And we want to make sure that folks go back to basics, make sure that they really understand how to do eligibility determination well, and it fits best the needs of your clients. So with that, let's move on to the next slide, please. Now, today we're going to discuss several issues. First of all, I always like to sort of identify the rules that we need to work in before we get into some of the practical aspects of eligibility determination. So first, we're going to just do a brief overview of the Ryan White HIV/AIDS program eligibility determination and payer last resort requirements. We're going to talk about eligibility determination basics, effective strategies for assessing household size, income, and health insurance eligibility. And we're going to be talking about working with your clients and your subgrantees' clients and their households to find the best health insurance plans that fit the needs not only of your clients, but their households as well. Now, we're also going to talk about who on your care team or on your subgrantees' care team can play in promoting optimal health insurance enrollment. We're going to also then close with a brief discussion of eligibility determination documentation, quality management, and improvement. Now, we have a really mixed array of folks on the call today. We have lots and lots of Part A and Part B grantees, as well as direct service providers, TA providers, and an assortment of other folks that are working in the HIV/AIDS community. And so I welcome you. I do want to point out that we have almost 40 different states represented on the call today. And so I think that's a testimony to how really pressing the need is to get information out around the basics related to eligibility determination. Next slide, please. So why are we needing to conduct eligibility determination? So first of all, obviously, for those of us that are funded under the Ryan White program, we need to adhere to the policies set by the HIV/AIDS Bureau. These policies are auditable, both among grantees as well as their funded providers. But most importantly, the policies really reflect the federal requirements for programs such as the Ryan White program to make sure that we really are adhering to the statutory authority of the Bureau as well as to the requirements that they and we need to live in. But also, there are a lot of other really important reasons to conduct eligibility determination. First of all, I like to point out that we need to make sure that clients receive the optimal benefits they are legally eligible for. We also need to make sure that not only our Ryan White clients, but their household members receive affordable health insurance coverage that meets their clinical needs, including medication coverage. We also need to address access to a full range of health care benefits, including those not covered by the Ryan White program. Now, for many folks, we need to also recognize that health insurance is part and parcel of the benefits that folks that are low income and or disabled receive. And so we need to make sure that they're enrolled in the programs that not only get them health insurance, but also provide them income assistance because of their disabilities. And then finally, it's really, really important now, more than ever with the Affordable Care Act, that we're helping clients to access health care medications through premium assistance and other health insurance wraparound programs. Over the last year, this has become an incredibly critical role that we're all playing in the HIV community. Next, please. So I'm going to talk as briefly as I humanly can about the requirements of the HIV/AIDS Bureau. For those of you who are particularly subgrantees, vendors, providers, clinical providers, frontline providers, the HIV/AIDS Bureau has a series of policy clarification notices that are posted on the HIV/AIDS website. And I really challenge folks to make sure that you, your frontline workers, your subgrantees, and other folks in your community, including planning councils, really understand what the requirements are. There's been tremendous numbers of questions and sort of repeat questions over and over in the last year or so. and it's pretty clear that folks haven't really been able to digest or understand the policy clarification notices. Before we get started, and as you're thinking about your questions that we can explore today, I really advise you, if you have a question and you're a directly funded grantee by HRSA, by the HIV/AIDS Bureau, if you have a question, please ask your project officer to put in writing a response specific to your query. If you're a sub-grantee or a vendor that's funded under Ryan White and you don't understand some of the information provided today, it's very important you ask your Part A, your Part B, C, D, or F grantee to explain to you what their policies are, and that will become a little bit clearer as being an important point in a few minutes. Next slide, please. Now, I'm going to go through very quickly some of the policy clarification notices, 3 in particular that address eligibility determination requirements. Now, many of these requirements were embedded in the original Ryan White Care Act. They've been in existence for many, many years, but for quite a while, the emphasis was not on audit, was not on exact specification and adherence to the policies, and so HAB has re-clarified those in these policy notices. First of all, there are some specific criteria in order to participate in the Ryan White program. Many of you, I know, are absolutely clear on this, but folks have to be diagnosed with HIV or AIDS, and they have to be low income as defined by your Ryan White grantee. So this means your Ryan White Part A, B, C, D, or F grantees. Grantees, planning councils, consortia get to then define further eligibility criteria for their specific service area, and they can address different income levels, geographic specification, and so on, primarily because we need to make sure that each grantee has sufficient funds to pay for the services for enrolled clients. Grantees can also establish and monitor the procedures to ensure that their providers are actually verifying and documenting client eligibility. Now, I hope you all know over the last few years there's been a slight adjustment in terms of recertification. And basically what you are doing in your eligibility cycle is verifying initial eligibility and then recertifying every 6 months to ensure that folks still maintain their Ryan White eligibility criteria. And they need to make sure at 6 months, you need to make sure that client's residency, income, and insurance status continues to meet your grantee's eligibility requirements. And you also need to verify that the Ryan White program is the payer of last resort. You also, during that recertification period, need to check for availability of other third-party payers that the client might be eligible for. Next slide, please. Also, for Part A and for Part B grantees, clients must be determined within a very specified time. It has to be at least every 6 months. Some grantees have slightly faster recertification cycles for a variety of local planning and program monitoring purposes. Grantees are able to add some flexibility and timing in that process, and they can readjust their eligibility cycles to be in sync with the Affordable Care Act's marketplace enrollment periods, where enrollment would start January 1st of each year. But then in the next intervening 6 months, that recertification would need to occur. And then once a year, at least, either a 12-month period or during the calendar year, recertification must include more in-depth supporting documents. Now, folks are allowed as grantees and providers to accept in the intervening 6 months a self-attestation from clients that nothing has changed. Essentially, everything is still in play, and they continue to be eligible for the Ryan White program. Sorry, my screen just went blank. Now, I have found in doing chart audit that many of the self-attestations were based on an initial intake and certification process for which clients actually had misinformation that had been received. And we had found that folks, for example, reported that they had insurance, but that was not actually entered into the system. So you need to make sure those research self-attestations are actually accurate. Also, you need to make sure that whatever appropriate documentation of the salient activities to determine eligibility are actually documented with either actual documents or some other workarounds where clients may not have sufficient documentation of some of the criteria for eligibility. Next, please. Also in this clarification policy notice, we are also need to make sure that the appropriate documentation is in whatever form that the grantee normally would require, either in a careware database, other electronic health record systems, whatever you have agreed to with your grantee, you need to make sure that that actually is complete. That also goes for paper charts if your agencies are maintaining those. Now, there's been a lot of advancement in our ability to make electronic our records for eligibility through careware and other resources where we can do data sharing agreements across agencies. And in many local communities, they acknowledge that the determination process is very burdensome for clients. And if we require every agency to verify eligibility, clients can spend hours and hours going through a tremendous amount of paperwork. And so the Bureau has agreed that if a data sharing agreement is in place, there can be a centralized eligibility determination process, for example, established by a grantee to lower the burden and to be able to streamline the eligibility determination process. Also, for Part B grantees, particularly in their role in managing the ADAP program and insurance continuation programs, many of those are doing sort of ongoing online verification through a variety of different electronic verification systems. And so they do have an opportunity to conduct a different sort of recertification process. Also, for those of you who are funded by Part C, D, or F grantees, you are really encouraged to look to and talk to your Part A and B grantees to see if you can join in some of those data sharing agreements. Now, once again, these are commonly very, very carefully HIPAA compliant, and so if clients have concerns around that, you can share and address those concerns. Next, please. Now, in this next policy clarification notice, we've segued over to 1303. This has been an area of confusion for many grantees, so we want to just go over it real quickly. Grantees, your Part A and Part B or other grantees that have contractors are required to ensure that their subgrantees make every reasonable effort to secure non-Ryan White funds whenever possible for services to clients. I want to reiterate, reasonable efforts whenever possible. And we know that there are some efforts that are unreasonable or impossible, and we can address maybe some of those during the Q&A session. Grantees and their contractors are expected to what's called vigorously pursue enrollment in healthcare coverage for any clients that may be eligible. And we can flesh out the concept of vigorously pursue also in the Q&A if folks are unclear about the depth and breadth of your vigorous pursuit. Also, grantees and subgrantees are required to enroll their clients in healthcare insurance coverage whenever possible or applicable, and they need to be, as clients, counseled about the consequences for not enrolling. And those consequences commonly are related to any tax payments that they would have to make because they are not insured in health insurance under the Affordable Care Act. Grantees are also able to consider requiring proof of Medicaid and marketplace notice of eligibility and the annual recertification to reduce the burden on clients. And so getting the acceptance letters, for example, the enrollment letters or the rejection letters are an important process, but clients should never be advised to apply to a program like the marketplace or Medicaid simply to get rejected, as has been in the past in play in some communities. Next, please. Now, the Affordable Care Act helps us to really streamline the method for determining financial eligibility. And there's a new math activity, math calculation, that HIVAIDS has asked us to use where it is applicable in the states in which have done either expansion, if your clients are enrolling in Medicaid expansion, or CHIP, which is the Children's Health Insurance Program for low-income children. And so in applicable states, we need to use the MAGI method of mathematic calculation. There are a lot of materials on the internet, so I'm not going to do math for you today. And if you have any questions about how to get a hold of the calculation, simply have to Google ACA and MAGI, and the calculation methods from the IRS will pop up magically. Now, also, we need to be cognizant that there are some folks that are ineligible for enrollment in Affordable Care Act Marketplace Qualified Health Plans. These include folks that are ineligible because they're elderly and should be enrolled in old age survivor benefits and Medicare, individuals that are disabled and receiving supplemental security income, individuals that are long-term disabled and getting SSDI, as well as medically needy. Also, it's really important for you that are grantees, many of whom are on the phone from Part A and Part B, to make sure that all of your subgrantees are actually using the appropriate calculation of household income and that they understand how to do the math. Many of us got into the programs and agencies that we work in not because we wanted to do math with our time, and I do know that there are math calculation errors that are pretty common in eligibility determination, so we need to make sure folks understand how to do the calculations. Next, please. Now, next we're going to go back to some basics. Now, I just want to sort of reiterate sort of the basics of the eligibility determination cycle as I kind of envision it. Now, a lot of what I'm going to talk to you about is really based on a project that we did with HIVAIDS quite a few years ago around eligibility determination training for Ryan White providers. And it's sort of fundamental basis or the basics of social work practice that many of us practice either as social workers or because many of the folks that are doing eligibility determination are case managers and use really fundamentally a social work model. So in terms of eligibility cycle, we need to start with new clients at intake and assessment. There's a lot of materials depending on your grantee's requirements that need to be collected, documented, filed to show that you've done a thorough and accurate determination process and that the client is in fact eligible for the Ryan White program. It's helpful, and I'm now particularly critical that for clients that are not insured or that are having challenges with their insurance plans, to help them enroll as quickly as possible based on their individual as well as household needs, and making sure that we're as in sync as possible with ACA marketplace enrollment, if open enrollment is available, if there has been an event that would make them eligible during the period between open enrollment cycles, then assist them to handle that and so on. Also, we need to remember that many, many folks that we're working with actually are employed and are offered employer-sponsored health insurance plans. Often this is a better financial deal for the client, has much lower rates, and much more transparency in coverage, and out-of-pocket costs. And so it's important to remember and to remind clients, do an open enrollment for their employer, that they actually seek enrollment or seek assistance in helping to pick the insurance plan that fits the best. Also, we talked about that 6-month interim reassessment period. Now, it's important to note that often during a 6-month and 12-month cycle, really important milestones occur. Clients get married, clients get divorced, they have children, infants, and are very low income and might be eligible for TANF. Folks move from state to state and so on. And so when a worker that's doing eligibility determination for your agency or your subgrantees agencies are aware of a material change in the client's circumstance, it's really important to do something about that. So if a client says, I've just gotten a new job, I'm going off of Medicaid, then that's a critical time to have a conversation about the health insurance benefits that are available to the client and so on. Now, some clients are going to be perhaps suddenly getting a job and making a lot more money that offers through their employment insurance enrollment, and they may no longer be eligible for the Ryan White program. Please do not wait until the recertification period begins to do something about that. We have a lot of demand on the programs now, and we need to make sure that we're keeping up with eligibility and so on. And this is a cyclical process that should go on quite commonly throughout the life cycle of enrollment in the Ryan White program. Next, please. Now, I just want to point out, particularly for those of you who are grantees, who have asked your subgrantees or providers to use a standardized set of forms for eligibility determination, that it's very important that you look at the reading level of those forms. This is the example of a reading level assessment that I completed for a Part A grantee a few years ago. And they have, as you can see, all sorts of forms that have to be completed by the client, by case managers, by supervisors, and a dizzying array of other folks. And so we ran eligibility of reading level checks on those forms. And we found that some of the forms had extremely high reading levels. And as you can see here in the far column, the reading levels for some of the forms were very, very high and, just were unintelligible. Those primarily were written by attorneys for the grantee, not really using plain language policies by Health and Human Services or common sense in putting together those forms. And so it was of no surprise that clients and case managers had a really hard time meeting the requirements of the documentation because the forms were just not clear. And so I would challenge grantees, or if you're using your own eligibility forms in your direct service agency, to check the reading levels, both in English and in Spanish, as well as any other languages that you may be producing your forms in, to make sure that they can be understood and easily completed not only by clients, but the workforce that we're employing to do eligibility determination, as well as other services. Next, please. Now, I want to talk about the building blocks for eligibility determination real quickly. And, I spend, as I may have mentioned, a lot of times looking at charts for a variety of different reasons all across the country. And what I've seen over the years is a real move towards focusing on an individual client without particular query as to who's in the household, the relationship to the client, whether the household members pool their income with the client, other information that would be helpful to know about those household members, including their employment status, as well as the general profile of what sources of income other household members have. Now, why do we need to know that? First of all, now under MAGI, we're looking at household income. And each of your grantees should be telling you how they expect household to be defined for eligibility determination, for participation in the qualified health plans in marketplaces and exchanges, that household income criteria varies from place to place and state to state. But it's very important not to only focus on the Ryan White client as if they were a single adult, particularly if we know elsewhere and documented in the chart the client is legally married, they have children they're supporting in the household, they're pooling their income with their elderly mother, which is very common, and so on. And so here's just a really quick example of what I would do if I was trying to understand the household. Not so much to ask for tons of documentation about every individual in the household, but we need to understand as we're computing household income, who's in the household, if they're employed, if they have other income, so that we can do an accurate estimation of household income. Next, please. Now, let's talk a little bit about income sources that we need to be aware of during certification and research. Now, I think all of us can agree that we need to be checking for earned salary or wages. We have a lot of clients that are fully employed. Many of them have a couple of jobs. In fact, many are employed part-time with several jobs, or we're seeing increasingly many clients that are self-employed. But we have clients that receive income from lots of other sources, and I've outlined those, and I'm not going to go into a lot of detail. But it's very important for grantees as they're setting up their standardized forms, for example, to provide directions so that the eligibility work that's being done is consistent and that we're not choosing to collect information from some clients that self-report and provide us lots of detailed information opposed to those who we really need to probe for some more information. And so these are a variety of sources. There is also an IRS document that you can't see here, but it's really a reminder to you and me that there are a lot of self-employed individuals, and their tax filings vary depending on their corporate status and how they're earning their self-employment income. And so for those folks that are reporting self-employment, it's really important to ask for the appropriate forms that have been filed, not the ones that they're creating in QuickBooks or other ways, but the filed forms so that we can verify their income. And this can be very complicated. You may have to look at profit and loss statements and so on. That's where the bookkeeper in your organization, the person that does payroll, may be able to help you wade through those income and loss statements so that you can understand what a client's income is, whether they may be sheltering income in their corporation, and so on. Next, please. Now, there are many clients in the Ryan White program that are reported to have zero income. And this is possible in America, although I think most of us would find a hard time trying to live that way. But there are clients who virtually do have no income, and they're heavily reliant on our community resources. And so, basically trying to figure out if those clients are the ones you're looking at across your desk, or if folks may be confused about what they're supposed to be reporting in terms of income. And I'm not going to go into all these questions in detail, but I would suggest that for those of you who are working with zero-income clients, you need to walk through these questions with them so that you can actually be confident what they're telling you is verifiable, that they've actually explored opportunities for income, including all the different programs identified here, with the purpose to make sure if you have a client that has no income, it's critical that we assist them to receive the income for which they're legally entitled, once again. Now, also, we have many clients that are being asked for and are providing letters of support. I often see letters from a spouse indicating that the client has no income and they're being supported by their legal spouse. That is not zero income. In that circumstance, that individual should be reporting the household income, including their spouse. Now, I know there's lots of different circumstances where legally married spouses are separated, they're no longer pulling their income, but you need to document that. And it's important that you look at other records that the client's accruing, including the medical records, where we often see clients that are reported to have having zero income are asking their clinicians for a letter for their employer indicating that they had to go to the doctor's office. So that collateral information elsewhere in the record can actually become an audit issue if you're not aware of it and do something about it in terms of updating the eligibility documentation. Next, please. Now, here is just a very, once again, Mavis's family is our example. And once again, with the household membership, and this is purely a example, not a real client, but I've come up with some theoretical income, the sources of income, and so on. Now, what's important in this is to be aware of not only the total income in calculating the MAGI, but also in making sure that we understand whether or not Mavis has income and what source that would be, particularly because the information that we see here indicates that Mavis is receiving disability income. And so the next question I would be is, great, Mavis, you're on SSI. Now, can I please see your Medicaid card? Because if you're enrolled in SSI, you should normally be eligible also for Medicaid in your state. So that would indicate to me that Mavis has health insurance through her Medicaid program. Now, for those of you who are grantees and you're trying to get a handle on auditing around income verification, often for my chart review projects, one of the first things I do is look at income for individuals that report no health insurance, those ineligible for insurance, uninsured individuals. If you have a client that's reporting they make approximately $8,796 a year, that is the total amount on SSI that an individual would be receiving. And I can tell you that I see those figures constantly when I'm doing chart audit, and I look at their records, and yes, indeed, they do have insurance, and they're eligible for Medicaid and, in fact, enrolled. And so these are quick things that we can do using our client-level data to do some quality insurance management work and to be really helping our workers to understand the relationship between disability, income, and enrollment in health insurance. Now, once again, for those of you who are a little confused about how to calculate MAGI, the website is shown here on the slide. Next, please. Can we move to the next slide, please?
Can you see the next slide, Julia? Common
no,
errors?
I can't.
It's still not working for you?
Nope, I do not see it advanced. If the next slide is on the screen, I have a paper version, and we can just keep going.
Okay, I believe it's on the screen. I don't know if it's what the error is, but it should be on the screen.
Okay, well, next we're going to talk about common errors in documentation and household size and income. Is that the slide you have up now?
Yes, that's what's up. Yeah, I'm getting
let's just keep
from
going, and we'll forge ahead. Now, once again, through chart review, chart audit, we find a lot of common errors. And once again, many of us didn't go into social work, case management, or other jobs because we were doing a lot of math and thought we would be managing paperwork and not clients. So that's totally understandable, but let's talk about what we commonly see as errors. Some of these I want to point out also can lead to audit errors for which your agency might actually have to do payback to your grantee if we see a practice that would appear that there's systematic underreporting of income and insurance. So having said that, let's move forward on a positive note. First of all, it is very common that there is absolutely no discussion of household membership. You would think that the client lives in a bubble. They have no roommates, no spouses, no children, no anybody in the household. And that very may well be the case. But often we'll find through collateral information, including progress notes, clinical records, that in fact the client does reside with a spouse, has a number of children, and so on. Also common errors around household income, including the income itself is poorly documented. We often see folks indicating they're self-reporting income, but we don't see accompanying documentation. And that is not just at research, but also at certification and 12-month research. Commonly, pay stubs are sometimes missing, but more importantly and very commonly, a miscalculation of total earned income, not only for the client, but the household, is often, yes. Hello?
Hi, Julia. We actually lost you for a minute there.
Oh, I'm sorry.
That's okay. So I'm still, can you see slide 17?
No, I cannot.
Oh, you still can't see slide 17? Okay, I think we lost audio from you in the middle of when you were discussing the common errors in documenting household size, which is slide 17.
All right, well, let's just move. Can you hear me now?
Yeah.
Okay, so let's talk about income real quickly. First of all, and these errors are obviously laid out, but I just want to sort of underscore a few things. First of all, we're seeing pretty poor income documentation, not only of the applicant or client, as well as their household. And so it's really important to start looking very carefully at the work that your frontline workers are doing. Supervisors should be held responsible for verifying some of this information as part of their routine self-audit, and so you shouldn't wait for a chart reviewer or your grantee to highlight some of these errors. Self-reported income commonly is not documented well with accompanying documentation. There are clients that do not report to the IRS, I understand that, but there are other workarounds that we can use. For those folks that are employed, pay stubs for not only the client, but their household either sometimes are missing. There are not enough either payroll cycles, maybe just a 2-week payroll pay stub may be shown as opposed to a series of pay stubs that would be able, particularly if the client has variable income, those working hourly on commission, so we can actually get a pretty good average calculation. But also we really need to have the household members' income reported as well. Self-reported income tends to be very spotty. We also tend to have very poor documentation for folks that are receiving unemployment, compensation, workers' comp, disability payments, pension benefits, alimony, and child support. And remember, because many of our clients have children in the household, that child support is income. Also, as I mentioned before, the zero income claims need to be explored with your client. In some communities, they're continuing to use SNAP or food stamp benefits as income. It is not fungible income. It is basically not something we can convert into cash, so it isn't actually income. Now, for many folks that have somewhat difficult recall about their income, there are a variety of ways that you can query that income. Now, with the IRS participating fully in the marketplace, that's helped us a considerable amount to understand what folks' individual and household income earnings are. But I would, once again, make sure that folks are giving you actual tax filings, not ones that they can easily generate. We need to know what's actually filed. And then we need to also avoid basing our six-month self-attestation on faulty information that was received at initial certification or at 12-month research. Okay, next please. Now we're next going to move to pathways to health insurance, and so we can move on to the next slide. And are we there yet?
We are there.
Excellent. Okay, we're going to do this virtually throughout. I'm flying blind. I hope we can make it work. Okay, so I just want to point out, because with the introduction of marketplace enrollment, there's been a lot of excitement, I'll call it, generated around helping clients get into a market or exchange-based qualified health plan. And for many clients, that's the perfect fit for them. But in that rush to help folks get enrolled, it seems that we've kind of forgotten of other really important pathways to health insurance. This has become particularly an issue as we've realized that many of the marketplace plans require a lot of out-of-pocket payments that we had not anticipated when folks were enrolled in that plan, and that some clients are finding to have a lot of difficulty, and they may or may not be eligible for assistance through their ADAP or insurance continuation program support, or they may be ineligible for premium assistance. So I just want to make sure that we set the clock back just a second and talk about other insurance that is very likely in many circumstances to be available to your clients. First of all, as I've said, many clients are employed and are offered employment-based commercial health insurance. Those are commonly based on very large insurance pools, so the out-of-pocket payments for those plans tend to be much lower. And we also have much better transparency because the employers expect it when they are agreeing to a contract with a health insurance plan. And so it's very important, if a client is enrolled, to verify that enrollment. If they're employed, to very directly ask them what's offered. But I also, when I do chart review, I have my handy cell phone there, and if it's an employer I'm not familiar with already, I look at their HR website and find out what insurance is being offered. And that takes me usually about 60 seconds at most. We also need to look at the spousal or parental employer-based insurance that's available under family plans. And we often find that clients are in fact eligible for spousal benefits, may in fact already be enrolled, but may not realize it, may not want to use the insurance because of disclosure issues. Also, commercial insurance can be purchased for those of us that are self-insured or self-employed. Some of that insurance may be through SHOP plans for small businesses, but there are other insurance policies available. Now, obviously, enrollment through the marketplaces or exchanges is also an important option. However, many of our clients are too disabled to actually be able to have the kind of out-of-pocket payments that would be needed, and so that is not a really good fit for them. In fact, if they are in short-term disability, they should be applying, and you should, in your organizations, be assisting them to enroll in SSI or enroll in SSDI if they're long-term disabled. And if they're at 65 years of age, many clients, but not all clients, are eligible for Medicare. We do have some senior citizens that are undocumented in the U.S., or those who have always worked off the books, and so they have not paid enough in to the system to get their quarters in. But we need to verify that. And if a client is not sure about their expected old age benefits, they can ask online for Social Security Administration to do a query for them so they can find out when their benefits would kick in and get enrolled at the important time. Also, we have lots of folks that continue to be eligible for Medicaid, even in non-expansion states, either through traditional Medicaid, through expansion, or under waiver demonstration programs. Some clients that we work with are eligible due to their either current or previous military duty in TRICARE or the VA. And then we have some clients that are eligible and can access insurance through trade associations. I grew up as a child in the Plumbers and Steamfitters Union Health Insurance Plan. Those union programs are, in fact, available to some of our clients. Also, there are other associations, the Bar Association, for example, AARP. Those are all associations for which insurance may be available. And then also it's important because we have many clients that are in college or universities. Many colleges and universities now require college students to be enrolled in health insurance. The days of college health services are long gone, and so many of them are requiring health insurance for full-time students. Many of those insurance plans are actually some of the same plans many of us enroll in, and so you need to verify, usually by looking at the website of the academic institution. And then in many of your states, and I've looked at the states that are represented today, many of you continue to have state or local public health insurance plans that you may need to be aware of, and so on. So next slide.
Got it.
Great. Now, I do want to highlight, where those criteria that I've just discussed are not available. Marketplace qualified health plans are a wonderful opportunity, and I don't want anyone to think that I'm not totally supportive. So for those folks where this is the best fit, we have a lot of technical assistance available through the JSI ACE Center that's highlighted here, and they have an excellent eligibility decision tree that you may want to use. Once again, it focuses pretty specifically on the client, so you want to make sure that you are, in fact, considering the fit not just for your HIV-infected client, but the household as well. But the flow through the decision process is really clearly and excellently amplified here. So once again, making sure that's the best fit, because we have found that for some folks, this is an issue in terms of out-of-pocket payment and coverage issues. Next, please. We're going to move on to SSI real briefly.
Yep.
Now, many of our clients have been disabled for a period of time and need to go through a disability determination process that is commonly packaged and submitted to Social Security Administration. However, the determinations themselves are done at the state level. And we're finding that often the client's claims for their initial applications are summarily dismissed for a variety of not particularly clear reasons. And often that dismissal is at the state level. But it's important to note that many folks should be and can be shown to be disabled, but it's critical that the clinical package that must accompany the claim is very well documented. And many clinicians really need to be trained how to do that. And so I show here the website for all the state disability determination agencies, and you may want to look at that. Next slide, please.
Got it.
Now, I just want to highlight a fine point here. Determination rates, the allowance rates for SSI applications vary considerably from state to state. And so you may need to really be working with your state disability folks to educate them around HIV, but also note that many of the successful claims are not based on HIV. In fact, other chronic diseases, including mental illness, tend to achieve better claims acceptance rates than HIV, because many of our clients now are able to live pretty healthy on their antiretroviral medication, but may have very serious schizophrenia, long-term other mental illness, may have uncontrolled diabetes, and so on. And so it's important to look to other criteria for that enrollment. Next, please.
Yes.
SAMHSA is wonderful in supporting the SOAR project. For those of you who are unfamiliar with either the SSI program and the determination process, or want to fine-tune your skills, SOAR training is available online. They have tons of webinars, helpful hints, educational materials. Many of us have been through SOAR training, and it is extremely helpful and can significantly increase the positive acceptance rates among our clients. So I would really, really stress that this is an important resource. Next, please.
Yes.
Next, we're going to talk very briefly around SSDI. This is a program that is designed for folks with long-term disability criteria that you can see here. I do want to point out, since some of our clients have end-stage renal disease, if they fit that criteria, they can apply directly to Medicare. They do not have to enroll first in SSI. They can go right to SSDI and to Medicare. And so you need to talk to clinicians that are working with those patients to determine if they meet the clinical criteria. And the application process seems to be very streamlined. So it's an important opportunity for our clients if they meet the criteria. Next, please.
Yep.
Now, I'm hoping that folks are aware of HIVAIDS, HIV-positive veterans policy. I'm not going to go into detail. All the materials have been on the HIVAIDS website for quite a few years now, and since 2004. We do find that there are clients that are VA eligible. Often that is not identified at intake, and so it's really important to be querying clients. I would not assume that veterans benefits are only for senior citizens or folks that were in the Korean or World War II or Vietnam Wars. We have many folks that are returning into the community that are eligible for VA, and so we need to make sure we're clear about eligibility and what other requirements has related to that. And I won't go into that in detail, but I would suggest that you need to look at the policy. Next, please. So we've done a review of the sort of basics around how to determine household size, income, insurance opportunities. And I want to just talk briefly, because I want to open up for questions, related to some helpful hints, some practical things that you need to sort of have in your toolkit as you're doing eligibility determination. First of all, I cannot suggest more strongly that pay stubs are a resource for determining a health insurance enrollment. It would include the actual name of the employer, and we often find deductions for medical, dental, and vision benefits that are missed by the person looking at the pay stubs. And so if you haven't trained your workers how to read a stub, or they're not clear what some of the deductions are, once again, your payroll staff might be able to help. I've on occasion looked up the names of some of the deductions and find out that they were a specialty insurance plan I was not familiar with. Once again, directly asking spouses or asking the clients about the spouses that are in their household and whether they're insured should be done every single time with a client. Even if they've indicated other circumstances, it's very important to directly ask them. If they can enroll through their insurance and their employers, you need to ask them if they're doing so. You may, and depending on the policy of your grantee, ask for documentation that's generalized, does not have to refer anything related to HIV or to the originating requester of the information. They have whether or not information about whether or not the client has health insurance coverage that's available, or it's available through the spouse, and that should be verified if you can't verify through the HR websites. Next, please. Now, there are other tricks of the trade that you might want to consider. Many of our clients are under the criteria of 26 years of age to remain on their parents' health insurance plans, either their mother, father, adopted parents, and so on. And so it's important to discuss whether or not they're on their parents' insurance plan. Now, I know many, many young clients are very concerned about their parents finding out many things, not the least of which is if they're HIV positive, as well as their gender identity and so on, and sexual preferences or behaviors. But it's important to dispel myths around explanations of benefits and other detailed information. Basically, any of us can ask for our EOBs to be submitted to us online. We never have to receive a piece of paper from most commercial health insurance plans, and they don't want to pay for the postage. So that can be addressed, and the control can be in the client's hands. Once again, querying about university or college health insurance availability among your clients that are full-time students is important. Also, many of you should have a Medicaid number. In most states, that allows you then to do electronic verification. That can be done very quickly, either online or over the phone. And many clinics have adopted a pre-medical visit policy or pre-visit policy where Medicaid is queried systematically before each visit to make sure folks have not been terminated from their eligibility because of lack of recertification follow-up and so on. Other frontline workers have available to them either Medicare or commercial insurance enrollment query systems. These are really, really useful. They will tell you about enrollment in most major insurance plans in your health insurance market. And that can help you clear up either questions that you have that it would seem like the client should be enrolled or may be enrolled, but you're just not getting a straight answer. These systems help you to verify that. Next, please. Now, there are some legitimate things that we need to think about when we're working with clients. Clients still have very legitimate concerns around discrimination and stigma, and these are very real. And so we need to address those head-on and to explain about the process, the requirements, what disclosure means, what will or will not be disclosed by the Ryan White program, and so on. It's very important to address those issues. And then also to really explain why it is that we need to assist folks to get insured, and so we need to really educate clients about this, and this is becoming critical now with implementation of the ACA. Also, I think we need to be aware that some clients truly are very confused about their health insurance enrollment and are not particularly literate in health insurance, and so we need to be able to assist them and educate them around that. We also need to make sure that clients are helped to navigate the health insurance system. They need to often be able to read and complete forms for which their literacy levels may be a challenge, or they may not read the languages that the forms are available in. And so it's very common that we have to assist them. I've seen, however, it's very common in many programs that it's assumed clients will handle all the paperwork, they'll fill out all the forms they're supposed to, and they will, be able to take charge of this situation on their own. And then once again, e-verification is critical. Next, please.
We got it.
Great. Now, in the interest of time, I'm just going to go through the next couple of slides very, very quickly. There are roles and responsibilities for everybody on your team, from your fiscal staff, your grantees, and the contract and program monitoring staff you're working with, the frontline workers themselves, your reception staff, and so on. And here are some of the things that I really, really suggest that you take into consideration as you're reviewing your eligibility determination processes. One of the things I suggest to grantees and to managers is that they ask their frontline workers that are responsible for eligibility determination to say what they actually do versus what's in the policies and procedure manual. Because often I will interview the frontline workers and be told an entirely different story than what is actually in the minds of management. And because of caseload, timing, challenges with clients, challenges of clients not following up in providing documentation, we often find what's done is not really in alignment with policies and procedures. And so I think it's important to call a timeout, to hold everyone harmless, and to ask them what they do, and if they're not following the procedures, why? Are they just unintelligible? Are they too burdensome to the worker or the client, and so on? And then also just basic training really needs to be provided. We should not assume that every worker that's tasked with this job understands the healthcare market is extremely complex now, and it's become increasingly more complex over the last couple of years. And so we need to be aware of that and mindful of it and address the educational needs of the workers. Next, please. Now here's some other helpful hints that you can adopt. I'm not going to go into a lot of detail other than to point out that legal services now are really, really critical, particularly with clients that are trying to seek health insurance coverage through their disability claims. Often they're going to need legal assistance in order to handle the inevitable rejection of their disability claims. And so we need to be mindful and identify resources. Now also, it's important to understand that Social Security allows fast tracking of applications, as well as there are opportunities to educate your state-level disability determination folks, many of whom are not clinicians, about HIV and AIDS. So I would suggest that that's an important step. And then next, please. Now, we tend to forget that our very, very most critical staff person in the eligibility determination world can very well be the front desk person who's asking the individual when they come in for their visit about their health insurance status, their income, and so on. And many of us just take for granted that we say, yeah, nothing's changed, when in fact it does. And so it's really important, as you can see here, that every client should be consistently queried about certain changes, about their insurance status, before the visit occurs. And then once they're there, which is why you want the visit to go in hand with the verification system, is to sit down with them and find out perhaps why their insurance status has changed and made sure that, in fact, that's been corrected, get them back on Medicaid, and so on. Next, please. And then also some other helpful hints around eligibility determination. And this is really critical around documentation. I cannot express more firmly that documentation tends to be inadequate in many circumstances, and we need to make sure that every chart, either virtual or a paper, really substantiates the information that's being gathered and that it is accurate. Next, please. Now, I want to just talk very, very quickly for just a couple of minutes around eligibility determination, quality assurance, and quality improvement activities. And you're not expected to see the fine detail other than to say, because I do a lot of chart review, I put together a chart review tool that I would offer available, and folks just need to drop me an email note. And I'm updating it right now to reflect qualified health plan enrollment as well. There's a user guide that I have developed that is also a companion to the chart review form, and that explains why it is that certain items are on the form. So, for example, if I see a client is pregnant, that triggers a query in my mind to find out if they have applied for TANF. So you'll see items on there, and the explanation is addressed in the user's guide. Next, please. So we've used this tool in many communities, and I'm just going to very quickly tell you what we learned. We've reviewed charts, and this is a little out of date, but it's very consistent with those same communities in more up-to-date chart review. But we've looked in our company at 5 different Part A grantees. These are very large chart review projects, and they're in a variety of different states and urban and rural settings. Next, please. And hopefully you can see in the next slide that where we were looking specifically at household size and household income, there were very high error rates that were identified in that process. And these are the average rates. In some individual providers, we found that, for example, up to half of the charts did not substantiate accurately the household size. In others, it was a lower number. Also, similarly, household income tended to be very poorly ascertained and reported, and health insurance, fortunately, was not as poorly identified, but continued to have a pretty high error rate. So I want to point out a couple of things based on that information. First of all, grantees should be doing their own internal audits of their sub-grantees, but also agencies that have pretty high volume may want to do their own quality improvement projects, specifically around eligibility determination. These are very straightforward. I'm happy to share resources with you if you all are interested in doing that. And with that, we will conclude the formal presentation. I will try to get relinked to the slide deck so I can see your questions. Marissa?
Hello. Great. So thank you so much, Julia. That was fabulous, and thank you for rolling with us blindly. And I think it ended up going pretty smoothly, so hopefully participants agree. I can read off the questions for you. We have about 5 different questions from folks, so we'll take the next 15 minutes to review kind of some of the questions. So if you have any additional questions, please feel free to use the Q&A box at the bottom right of your screen, and I will read them off for Julia to respond to. So the first question we have is, for the attestation, can it be a verbal attestation or is a written attestation required?
Well, once again, depending on your circumstances as an agency, if you're funded by a Part A, B, et cetera, grantee, you need to confirm with them what their expectations are. I would always advise that that be in writing. It's important to note that depending on the circumstance, if, for example, they're applying for funds for ADAP, that's a legal process for which, if they were, in some jurisdictions, found to have been providing misinformation purposely, that would be considered fraud. And I would certainly not raise that as a specter with clients. However, it's the reality of the grantee. And so in many jurisdictions, you will see that grantees have in the attestation forms a caution that the information should be documented accurately, and the client should be aware of penalties for providing misinformation. In other circumstances where you're developing your own forms, first of all, I would talk to the grantees. If you're funded by HAB directly, I would talk to your project officer about best practices and maybe getting copies of other self-attestation forms. Many grantees and providers have those in play now and are certainly probably easily retrieved from other providers. But I would never, ever ask someone to verbally confirm something along these lines. These are federal funds, and we need to make sure folks are aware of that. And none of us would ever, I think, be entering in to agreement with an agency in other circumstances where they would just take our word for it, and then in turn the worker would say, the client said this is accurate. There is no documentation or legal backup from that.
Great. The next question we have is just around clarification from someone. Do we not encourage our clients to apply for Medicare and Medicaid even though they might qualify for the services? If this is correct, how do you document this information?
If a client appears to be eligible, first of all, we in the Ryan White world are not making them eligible. So if it appears to you, and based perhaps on clinical evidence and so on, that the client is eligible, they certainly should pursue those benefits, and I want to make clear that that's critical. Not only should they pursue them for health insurance enrollment purposes, but if that's tied to a disability claim, many of those clients really need to have disability income. And so that should be pursued, and to the extent that it's reasonable. But they should, if they're applying for SSI, particularly for the first time, they should be prepared to be initially rejected. The rejection rates are very high in most states, well over half of the initial claims. And so they may need to be referred to a legal provider that can assist them either initially packaging their claim or to pursue their legal remedies if rejected initially.
Great. Our next question was in reference to the documenting income on slide 17, and they just wanted clarification around why food stamps are included as income in the calculations.
Well, I don't have 17 up, but it should not have been included because it is an income, but we do see that very commonly. And if you have been advised by your grantees about that, you should ask them upon what basis they're considering them to be income, because generally most grantees have now determined that they actually are not income because they're not liquid. We cannot cash them at the grocery store.
Great. Thank you for the clarification. I think because it says common errors, somebody may have been confused about why it said include SNAP benefits. So great. Next question is, could you share what the online eligibility verification process looks like for those of us who do not yet have something like this in place, but who are interested in implementing this type of a system?
Certainly. Well, first of all, in many healthcare practices, their electronic health record systems have a built-in feature that allow them to query through the EHR Medicaid verification records. That would be an online query. You would go in, type the basic information about the client, including their Medicaid number, for example, and that would tell you whether or not they have active enrollment and either termination date, the last date of recertification, and so on. And then it will tell you other information commonly, including if they're enrolled in a managed care organization that participates in Medicaid, the name of the plan, contact information, the enrollment date. If they were disenrolled for a variety of reasons, that information would be available. In some jurisdictions that, or among some providers that don't have electronic health record systems, there are collateral ways to get that information. In some jurisdictions, you can do it by telephone, where you dial in the number and it will basically give you information as a recording. And then in some places, you can go ahead and dial up through an internet access portal, and that will also bring up the enrollment information for the client. Then also, if it's a TANF grant, for example, whomever else is in that account, so the client may be a parent and the children are enrolled in her account, or his account, that would also show you information about the account size, the membership, and so on.
Great. So the next question is, what can we do as individuals if we know of a client enrolled that is not entitled to participate but is defrauding the system?
Well, I totally understand your question. This has come up on occasion. First of all, we have some clients that, clearly have very difficult challenges for a variety of reasons, and documentation may be a real issue for, just they don't have a place to keep paper because they're homeless. So we shouldn't naturally jump to the conclusion that fraud is in play. But I have worked with grantees and providers on many occasions over the last 20 years where it's very clear that something is going on. Often the worker is not really able to get their finger on the pulse of exactly what it is that just doesn't make sense, or where the documentation is very conflicting. First of all, if you're a worker in that circumstance, I would immediately discuss it with your supervisor. I would, if you're a case manager or other individual that's keeping progress notes, I would make a note in your progress notes specifically about your discussion, your concerns, because you need to show that you're doing your due diligence. On some occasions, and I'm just telling you about practices among agencies, I'm not advising whether they're good or bad, but in some circumstance, the client has been asked to come in, and the worker and their supervisor or others will counsel the client about the need to be honest related to the information that they're providing, any questions and the rationale for skepticism about that, and then explain, particularly if you're working in a jurisdiction for which there may be legal penalties if the client is not being honest, and they have signed in their informed consent that they have to provide accurate documentation. I would admonish them that this is a serious, serious issue. But I would also perhaps raise with them if they have concerns and don't want to disclose what those concerns might be. And some of them may be very legitimate. And I'll give you an example that's come up. In some circumstances, clients are on their spouse's insurance, and they're very worried their spouse is going to find out they're infected. They are, in some instances, worried about intimate violence and have been able to substantiate through medical records that this concern has been borne by behavior on the part of the spouse. And they're very worried that anything more might trigger additional action by the spouse. That's a very legitimate concern, but if they haven't alerted you to that, then you may not be able to quite put your finger on what the situation is. And that's just an example. There may be others. And in some situations, we have found that clients, in fact, were fraudulent. This doesn't happen much or often, but it has occurred on occasion, but it really has to be carefully documented. HAB in their policies has indicated that we cannot withhold services in most circumstances where the client has claimed an eligibility, provided what they've provided, and it appears that without other substantiating documentation, you can't decertify them. But I would also, in those circumstances, talk to your legal counsel and your agency just to make sure that they're aligned with your plan. And I would also talk to your grantee if you're not directly funded by HAB. And if you are, I would talk to your project officer. I would not disclose any patient information in communication and writing to your project officer, however, so you're not violating the confidentiality and the HIPAA rights of the client.
Great, thank you, Julia. We have two questions that are similar. So if a client's employer offers insurance, does the client have the option to decline coverage? And how would you handle that situation as it relates to eligibility for Ryan White coverage? And then the second question is basically the same. if the client indicates that he or she opted not to take coverage from their employer due to cost, how do you handle it?
Okay, well, this is where clarification needs to be provided to the client about the ultimate result of rejecting potential enrollment opportunities. First of all, there is very likely to be an IRS tax penalty, and so right off the bat, that's a really big issue. They also, I think it's important to discuss with those folks their actual circumstances in terms of the cost of the premiums and the out-of-pocket payments and why it is they would not want to uptake that insurance. I would also discuss with them if, in fact, the premiums and copays are high, whether or not they can seek assistance such as through the state ADAP programs, insurance continuation programs, or premium assistance that many of the Ryan White Part A programs have available to help them, so that they're aware that there may be very likely, depending on their circumstances, resources available to them that would help soften the blow of the expense. There may be other reasons, including not wanting their employers, quote, to know they have HIV infection. And I would educate clients that employers do not know what any of us have on board as employees in terms of medical conditions. They do not see our explanation of benefits, and they cannot see our claims. And sometimes we need to educate clients about that. The guidance that I discussed earlier in the slides indicate that there is an expectation that clients do pursue and enroll in those health insurance plans. On the other hand, there's also sort of the escape clause that we can't throw folks out of the Ryan White program simply because they refuse to uptake insurance. And I would not initially offer that as the exit for clients to get out of this, but I would very much query their rationale. I would also remind them that regardless of what the Ryan White program says in terms of policy, if they go into the emergency room or they have a hospital stay, they are entirely responsible for those payments. If they end up in urgent care, they need to see a clinician outside the Ryan White program. Once again, they are totally responsible for those health insurance bills, and they very well could be turned over to collections, and some of those bills could result in very serious financial difficulties, impact their credit rating, and other things. This is, a reality broader than the Ryan White program.
Great, and we just have one more question that we'll get to before we close the presentation. The question is, where you reference collecting household size and or household income in documentation, is that a requirement that's specific for health insurance eligibility determination, Ryan White eligibility certification, or for both?
It is required for both. First of all, we're to determine the household size and income to determine federal poverty level. Many of the Ryan White grantees have ceilings on income level based on the sliding fee scale, and the household size and income is in play there. So there may be an income ceiling. Also, to determine out-of-pocket payment for Ryan White, remember we do expect that clients share some of the cost under the Ryan White program, another topic for another webinar. And so we need to have that information for both rationales.
Great, thank you so much. So that pretty much covers, I think we got all the questions. If you have any additional questions, please feel free. I believe you saw Julio's email right here. He is the program manager for Fiscal Health. So if you have additional questions for Julio or for Dr. Hidalgo, please feel free to email Julio at healthhiv.org to ask that question. Also, I wanted to remind everyone that there will be a prompt to complete an evaluation. Again, we'd really appreciate if you complete the evaluation at the end of this webinar. And additionally, I received a few questions about the webinar slide availability and the recording availability. And I just wanted to reference where we do have archived all of the fiscal health webinars, including the one from June 17th last Wednesday. That's not currently on our site, but it will be available tomorrow for you to print either the PDF of the slides and or view the recording or download the recording. This particular webinar will be posted within 1 week as well. So by next Tuesday, you'll be able to access this webinar recording and the slide deck. So if you have any questions again about that, please contact Julio. Otherwise, you can find those recordings archived on Health HIV's website under Education and Training and the Fiscal Health Program. And also, I think, Julia, there's a couple of people that are asking about your chart review tool. So I'm not sure how you'd like to address that, if you want to allow people to email you or...
Yeah, if folks could just send me an email, that would be great. I just mostly want to make sure I explain how to use the form and in what circumstances, and just, you know, provide some coaching and excitement so that you're working in this arena.
Great. So you can see I just pulled Julia's email up. Hopefully not all 150 folks are going to reach out to her. She'll get a lot of emails. But if you guys have specific questions or want to access the guide, you can reach out to Dr. Hidalgo at her email address is on the screen now. And again, any other questions, please feel free to email Julio Fonseca. So without any additional comments, I will let you all go. Thank you so much for participating in our webinar, and we hope you'll participate again in a fiscal health webinar in the future. Thank you so much, and thank you, Dr. Hidalgo.
Thank you. Bye, everybody.
Bye.